various treatment approaches are being adopted, but no definitive result has been seen yet. So we invite Professor Dr. Mandip Goyal ma'am, Professor at H.O.D Department of Kayachikitsa, who has a vast experience in this field to enlighten us in this topic. Professor Dr. Sulakshana ma'am will be chairing this session, for which co-chairperson would be Professor Dr. Agnivesha, Professor, Department of Kayachikitsa. I request Professor Dr. Sulakshana ma'am to kindly present the floor of welcome to our eminent speaker.
It's a great privilege for me to introduce our esteemed speaker, Professor Dr. Mandip Goyal ma'am, a distinguished academician, researcher and clinician in the field of Ayurveda. Madam is currently serving as Professor and Head Department of Kayachikitsa and Dean International Studies at the Institute of Teaching and Research in Ayurveda, Jamnagar, an institute of national importance under the Ministry of Ayush. She also holds the important responsibility of coordinator of the WHO Collaborative Center for Traditional Medicine at ITRA. With over 25 years of rich academic and research experiences, she has guided numerous PG and PhD scholars and made remarkable contribution to Ayurvedic education and evidence-based research. Her scholarly work include more than 140 research publications, several editorials, book chapters and contribution to authoritative texts like Charutar. Professor Dr. Mandip Goyal ma'am is actively involved with national and international research bodies, ethics committee and editorial boards of reputed journals and has played a key role in WHO supported research project and formulation of standard treatment guidelines. Her vast experience, deep subject knowledge and dedication to integrating classical Ayurvedic wisdom with modern research made her an inspiring guide for students and scholars alike. We are truly honored to have you with us today, ma'am. With due respect, I hand over this diet to you, ma'am.
College in this one-day national seminar, Agnivesha 2026. First of all, I would like to congratulate the Department of Kayachikitsa who has taken up this responsibility, because I feel Ayurveda is growing, Ayurveda is developing, but there is lots of needs to think about what is the need of research in Ayurveda. Typically when we are in the field of health research, where we stand and what we have to do next. And if our next generation is ready for it, then only whatever we have done in the last few decades, it can be taken out or it can be taken forward in a right manner. So with this note, let us come to the topic. The topic which has been assigned to me, it is little bit a very vast topic because 3 points are being covered under that. It is preclinical and clinical trials. It is being followed by the need of pragmatic trials in non-communicable diseases, and also what should be the scope of research in Panchakarma, typically when we are talking about the safety related to the Panchakarma procedures. So whole discussion, because I know most of you are the PG and PhD scholar, am I right? So kindly raise how many are the PG students over here? Postgraduate students? Yes. And the remaining? UG students are also there? UG students are there or not? Yes. Yes. So I will try to speak in a way that both of the groups, they understand what is the need of research and how we follow the research in Ayurveda. So we will be starting with the first topic, which is being related to preclinical and clinical research. Next slide, please. See, when we are here, typically when we are considering ourselves as experts of Ayurveda, and Ayurveda is actually a textbook which is being related to the health. So we are directly or indirectly related to the health research. So when we are talking about health research, in modern medical science, which is also called as the conventional medicine, lots of advancement has occurred. You know, it is called as the modern medicine. Modern medicine means which has just started, or it has taken its journey in the last few decades. But when you look at the advancement which has occurred in the modern medical science, it is very vast and it is very rigorous. And why? Because they are following the word, it is what? It is like science matter, evidence matter, and it is also like trust matters. Means if you are working in a field of science, you have to be very scientific, you have to be very systematic, you have to be very methodological. You have to have evidences for that, and evidences should be generated in a way they are trusted or they are being authenticated. So health research is nothing, it is a simple phenomenon where we are trying to record various activities which are being covered when you are doing the patient care. And after doing that, you are doing a proper plan. For a new disease, it needed everything. Diagnoses were required, the treatment policies were required, guidelines were required, and for that a simple systematic way of understanding the disease was required, and that was what they started with some of the clinical researches. And they were not properly analyzed and interpreted. Maybe today also we were a little bit confused what was that COVID-19, what was the cause for it, and how it was being, how we manage or how we were able to manage it. And parallelly, we from the Ayurveda field also generated some of the pathogenesis, thought of what can be the line of treatment for that, and then we also executed many of the clinical trials, and the outcome of that clinical trials, it said somewhere Ayurveda can be a supportive treatment in the COVID-19, and these are the probable guidelines which we should follow from the Ayurveda point of view. And that was all documented, and it was being published by the authentic sources, that is from the Ministry of Ayush, and it was supported for Ministry of Health and Family Welfare. So this is, next slide please. And whatever research is, it is nearly like a translational research. It is also sometimes called as the translational medicine. And translational medicine and clinical research, they go hand to hand. Simply if you read there, it is discovery to delivery, or it is from bench to bedside, or it is from the lab to the bedside. When we are doing any research, many a times it is the new drug, it is a new drug molecule. It is not so much applicable to Ayurveda, but it is much applicable to the modern medical science. Because whenever they do, because it is a modern medical science, they are still emerging, they are still developing, they are in the need of finding some new solution every time when they have a new condition, or they are searching for some superior medicines, or because there are so many side effects of the known drugs which is already being given as a part of the treatment, they are in the search of safe and efficacious or safe and effective medications. And for them, this is a very strong process where they are trying to find some leads from the patient. Based on the leads from the patient, they are trying to develop a diagnostic tool, a device or procedure or a treatment guideline, and then it follows through the process, it gets approved, and then it is a approved drug or medicine or a procedure or a device for a purpose which can be used for the diagnosis or also for the assessment of the efficacy of the treatment. And so it always go parallel from the bed to the lab or from the lab to the bed. It is a vicious cycle. It is a learning phenomenon that we learn. See, suppose we are in the OPD setup, a patient comes, we are giving some medication to the patient responds to that medicine in a very different way. And then we try to find out when the simple drug was given, just to take an example, you have given Trifla to a patient. You are supposing that after giving the Trifla, patient may have a laxation effect, patient may have some of the anti-dyslipidemic effect, and this is what we are imagining and giving to the patient, looking at what is the need of the patient. But a patient gives a very different outcome of the medication. So this is a different lead. Trifla can also have this type of effect. It may be a side effect, or it may be a beneficial effect, or it may be a positive finding out. So we get a lead, and from that lead we start doing similar cases, similar dose, similar drug is being given. If it is being giving response, we may find that the Trifla may also have this additional property, or this may be the extra action or the karma of the Trifla. So this is how we do the learning, and because of that now case reports, case series, they are being documented, and from that we can get a new lead to either repurpose the known drug or we can have a new drug for a new condition. Similarly, there are basic science, and on the principles of the basic science, in the collaboration of the basic scientists, or who are the experts of the basic science, they are the experts of the pharmacology and the clinician, a group of it, they come together, they may define a new drug, it is called as the new investigational drug or investigational new drug, it is being there, and that has to go through the series of tests before it is being given as a proved treatment for a disease. So this is a whole phenomenon, and typically whether it is applicable to Ayurveda or not we will do later, but this is a simple process which is being now adopted for the modern medical science. Next slide. And so clinical research and translational research, they are very important of the basis of forming a new drug to taking it to the practices that is what using as a part of the therapeutic properties. Next. So typically, because the first point which was given to me was about the preclinical and the clinical trials. I know because you are the PG student, most of you will know these things, but I will just go through it very simply, just make you understand. And whatever I am talking now, it is to a new drug molecule, means which has not been studied before. It has to be used in the human first time, and so it has to pass through a rigorous processes to see that it is safe, it is effective, it has less of the toxic or side effect, or it has rare conditions where it can go to a very severe adverse reaction or something like that. And so the journey starts from the preclinical trials and it ends up into many phases of the clinical trial, right from the 0 phase to phase 4. And all these exercises is being done only to see whether there is a whatever you are expecting the outcome of the drug in a expected condition, it is working or not. So preclinical trials are the early part of the clinical trial, or it is just like you can say it is the Purukam procedures beginning for the clinical trials, where the drug which is called as the investigational new drug, it is first studied in vivo or in vitro, that is it is being studied in the lab to see which is the best positive potent drug molecule which can have the efficacy or effect in the targeted condition or the disease. Suppose it was a drug which they are thinking hypothyroidism. Hypothyroidism, they know the cause is what? It is the low thyroid hormone, and because of that the patient suffers from the condition or the sign and symptoms of the hypothyroidism. And now it is what? It is hormonal replacement therapy. It is thyronorm is given, thyroxine is given. So it is not there, we replace it. Now suppose the modern world is thinking of why not find out a different drug molecule which can stimulate itself the thyroid gland, and then it can have the effect of what thyroxine can do inside instead of the replacement therapy. So they may go for a search of a new drug molecule, expecting that new drug molecule should have an action of simulating the action of the thyroid hormone, that is TSH, and also having some impact on T3 and T4. So initially it cannot be directly given to the human saying that this is my thought, this is my idea, let me have this drug, see in the hypothyroidism patient that this works or not, because it is not allowed ethically. Everything has to be first accepted, approved, documented, then only it can go for the human trials. So preclinical trials are the beginning trial where in vivo or in the animals the experiments are being done, and with the experiments, if the pharmacokinetics it is being established, preliminary efficacy is being maintained, then it goes towards the clinical trial. Clinical trial means then it is being experimented in human. So before coming to the human clinical trials, they are done in the labs, or it is being done in vivo or in vitro, or many a time in silico profiling is being done, and based on that, if this molecule or the new drug molecule qualifies, then it is being after the approval as an investigational new drug under FDA regulation, it is now put into the human trials. Are you getting this point? Okay, somewhere I may also ask the question, so be very vigilant in the class or in the seminar hall. So this is a very simple way of understanding. Because the BMS students are also there, so I am making it little bit diluted so they understand what is the process. And then we will come to Ayurveda, whether it is applicable in our Ayurveda field or not. But we should be always aware of the things which are going around us and to see what the other science is doing and what we are doing. Whether we should follow it or we should not follow it, it is actually in our hands. But that we have to decide what is the scope in us. So the preclinical trials, later on we will think whether there is a need of preclinical trials in Ayurveda or not. And if it is there, then what is the drugs or what are the structures where we have to think of the preclinical trials. Okay, so it is this. Next slide please. So once it is a preclinical trial phase is being over, before it is getting marketed, it is into the use, it has to go through various phases, and if it is clearing each and every phase, it is step by step, and then it is into the use as a approved drug through a process which is called as the new drug application, which is then being approved by the FDA, then it is into the use for the human in the market. So many a times now what happens, we have some formulation in our books. We strongly follow those formulations without any variation in the formulation. We may not have to go through this whole process of preclinical or the phase 1, phase 2, phase 3 trials. But sometimes when we are doing the combination variation, we are trying to add or remove something from a known formulation which is being mentioned in our text, we may have to go for these steps. Typically when they are known toxic drugs or they have got some potent adverse reaction possibilities are there, chances are there where we can adopt for that. Now phase 0 trial, phase 1 trial, phase 2, phase 3, these are all clinical trials. Now why they are called as clinical trials? Because it starts with the human participants in this trial before it was in the lab or in the animals. Now when it is human trial, phase 0, it is called as first in human trial. First in human trial means what? After getting it approved in the animals, first time in a sub-therapeutic dose, in a very less, it is called as micro-dosing. It is being given to the humans, and then the pharmacokinetic of this drug is being studied in the human to see how the drug is being absorbed and where the drug is getting targeting the structures and what effects it is producing in the body, or it is just to understand what is the drug doing inside the human body. And it is in micro dose. Why it is micro dose? Because initially you cannot go to the therapeutic dose because still we don't know what is the actual dose of that drug. And we are in the process of developing the right therapeutic dose of it. Initially, if you give the dose as per the previous calculated doses of any other medicines, it may be a overdose or it may be even a heavy dose which may produce many complications. So it is first 0 phase in very less number of subjects in a very short duration period. The sub dose is being given and somewhere its preliminary efficacy and a dose is being thought, and then we get actually what we are targeting, the drug is reaching that part or not, and then it goes to the phase 1 trial. In the phase 1 trial, now it is, we go for a large but not very large sample. In small groups of people, it is called as the cohort. In that cohort, now little bit single advanced doses it is being given in a ascending manner. Means one dose, first dose is maybe some points, later it is little bit increase, and it is always with the control group. Because we want to see, if you don't have the control group, you cannot imagine what the drug is doing in the treated group or the interventional group and what it is happening where it is not being given. And similar, this process is maintained, slowly the dose is being increased, and that dose is now brought to a place where it is called as, it is the tolerability is achieved or exposure is being achieved, at that point it is thought this may be the best dose to have the desired effect of that medicine inside the humans, and this way the phase 1 trial is being over by single ascending dose to multiple ascending dose, and somewhere a first thought of the therapeutic dose is being made in this trial. This phase, it is called as the completion of the phase 1. Then in the phase 2, it is again whatever dose was being finalized in the previous phase, it is being given to the again subjects, but now it is being a larger cohort. Then again in the phase 2A, the dose is being, therapeutic dose is finalized, safety is being seen, and also the efficacy is being adopted, and somewhere the pharmacokinetic and pharmacodynamic effects of the drugs are being finalized. So somewhere now a rough idea, what is this new drug molecule, how much dose it should be given, how efficacious or effect it will have in the human body, it is being planned, and with this nearly completion of this phase 2 and phase 3 clinical trial, something it is said it is being finalized where we can go for a large sample size, where RCTs are being again carried out, and then it is a documentation where we see the effect of the dose with the some subjective objective outcomes with a very planned studies which is called as the RCT, or it is clinical trial based on the requirement of the research, it is there. And then phase 4, it is the post marketing, it is being marketed, it is available, but still the studies are going on to see if it is continuing or it is being given to a very large sample, what is the effect, what is the safety, whether there is any toxicity or there are any known adverse effect or there are severe adverse effect, everything is being documented and it is being a part of the pharmacovigilance. So this is what it has been from the 0 phase, from the clinical to the clinical trial phase 4, everything is being documented. And when this documented are showing that drug has got more of efficacy, less of the toxic effect, less of the side effect, then it is being declared that this is the best potent drug for that particular condition. Next slide please. And then based on the your research question, what is your investigation, various trials are being planned, and it is just the summary of it. We are not at this moment too much interested about the observational study. We are towards the experimental study or the explanatory trials, or it is sometimes even called as the traditional trials, which is then from the random to non-randomized and the randomized trial. And I am very sure till date many of us are doing clinical trials, and whenever we are clinical trials, we are being taught that RCTs are the gold standards. We should do RCTs, and maybe in the last many years, like last 20-30 years, we are being doing some RCTs, being a part of whether it is a postgraduate research work or it is a PhD research work or many such sponsored trials or projects we are taking. RCTs is always our favorite topic, because why we are taking RCT, what will be the outcome after doing the RCT, we are not very sure, but we are being said that RCT is the best way to evaluate the efficacy of a drug, so we always follow it. But the time has come, we have to rethink that whether RCTs are totally applicable to the health research what we are doing in Ayurveda. In the last few decades, being in a part of a research institute, being a guide of the PhD and MD scholars, what I have learned that RCT is actually not the solution for us. And it is not at least a solution for the condition where we are not trying to compare our drugs with the modern drugs. When it is a standard control trial, so just take an example. Recently we have finished one of our very important project. It was a project of PhD where we were trying to see the add-on effect of Ayurveda treatment to the patients of MDR, pulmonary tuberculosis. Okay. Now the question is very simple. Patients who are known cases of multiple drug resistance, they are already taking the modern medications. but modern medication has got many side effects of that medication itself. Can Ayurveda add something to reduce the side effects of the ongoing medications? Can Ayurveda drugs improve the quality of life? Can Ayurveda drugs increase the bioavailability of the ongoing modern medication? These are our research questions. So if this is a research question, RCTs can be done, because it will be one group will be standard of care, or it is where only modern medication is going on. It is nearly a control group where we are just seeing the effect of the modern medications and we are documenting it. And the other group is where in our study we had added Draksha Avale and Yavani Shadavadi Vati, and we are seeing the additional, it is now add on. So the second group was the interventional group where we were adding the Ayurveda treatment with ongoing modern medication. RCT was applicable. And then we could find out which is better by applying the statistical tool, and somewhere in the conclusion we could say that when modern medications, Ayurvedic medications are added to the ongoing tuberculosis treatment for MDR, these additional Ayurveda drugs, they improve the quality of life, they reduce the side effect, typically the side effect of the gastrointestinal side effects of the AKT or the modern pulmonary tuberculosis MDR drugs. And the death rate which was there in the control group, compared to that, the death rate or the number of the patients dying during or after the course was less in the add-on group. So here RCT is applicable. But when we do the RCT comparing two Ayurveda drugs, Yogaraj Guglu with the Triphala Guglu or Yogaraj Guglu with Dashmul Khwar, there we are doing some mistakes. And if you look behind, recently we have done a systematic analysis, review and meta-analysis. We could find that in the last 40 years, whatever we have done for the treatment of osteoarthritis, for the treatment of low back pain, none of the protocols were similar, and because of that, there was very difficult to come to a point saying that which Guglu or which formulation or which protocol is best for the treatment of osteoarthritis, because again there is a big variation in the protocols, big variation in the drug selection, big variation in the outcome policies, and big variation in the way we collect the data and we generate the information. So if it is not being, see, modern has advanced because it has adopted standardized. There is a standardized way of writing a protocol, there is a reporting guidelines, there is also some CTRI which is registering them, there is a way we are getting the institutional ethics committee approval, everything is being documented. Now we are also very strongly following, but then only it goes to and way it is called as the science matter, or it is the trust matter, or it is what the evidence it matters. So it should go like this. So next. Now little bit back to Ayurveda, because we are from the Ayurveda field, we should talk more about Ayurveda and we should see what we can do to our science. I called Ayurveda as research oriented medical science. Why it is research oriented? Next slide please. Next slide. This is one of the reference we get in our textbook. Charak, he is trying to repeatedly say you have to adopt something or you have to validate something before doing it as a best or calling it as the best. And experimentations are must to decide something. Validation is very important, and so we cannot say that Ayurveda there was no research. There was a research in Ayurveda, it was thousands of years back, and whatever you today see, it is based on some of the studies. Next slide please. Our principle of Karya Karan Siddhant, it is nothing. We are always seeing for what is the exposure and what is the outcome. This is the drug and this is the effect. This is the ahar, this is the effect. So somewhere we are trying to correlate with, and because of that we always start our treatment with Nidan Parivarjan. This is the Karan and this is the effect. So if the Karan is there, the effect will continue. So we have to remove the cause. So everything is being documented and has been processed like this. Next slide. These are some of the evidences we can see from our textbook. This is for our young scientists who are here. This is to bring in you the confidence that how we have seen our science developing. It was based on these all Sanskrit terms. Aptopdesh, Yukti, Pratyaksha, Anumana, Upamana. These are all points of research, and if you just go to the translation, what I have tried to put with these terms, it is all matching with what modern medical science is now doing in the health research. And it was done thousands of years back, where there was a literature review, because always you see, there is always opinion, re-opinion, there is a cross-questioning, there was Sambhasha, on the basis of the Sambhasha, there was a conclusion, documentation, commentary, so many things were going on. Maybe it has stopped from the last few centuries. It may have gone, it should have gone, but it has not. But we have to start it again. What is documented is sufficient, is very good, but we have to advance on this, and commentaries and the advancement of the Samhitas which came in the later centuries are the example of that. Yukti, we usually talk as Yukti Vyapashray Chikitsa. And when we say Yukti Vyapashray Chikitsa, it is what? We actually are logically planning for something. This is a disease, this is the Samprapti, this is the Samprapti Ghatak, and if this is this drug, probably this way will be the probable mode of action. And so when we give this drug in this dose, in this pattern, with this anupan, this many times for this much duration, probably this will be the Samprapti Vighatan. With this way, there will be changes in the sign and symptom. This is what we call as the Yukti Vyapashray Chikitsa. Same is that we can apply for the health research. We have to logically plan for the things. Whatever is being mentioned in our text, as I have said, it is research oriented, it is being validated, but sometimes it is a need for revalidation. So if we are going for the revalidation, we have to think for how we plan it appropriately so that the outcomes are fruitful, they are useful. Similarly, Pratyaksha. Pratyaksha is what? Now you start executing the whole plan. Writing a synopsis is the first step in your MD research work. If your synopsis is properly planned, properly written, everything is very well documented, and you are knowing what you want to do exactly, then only it will be properly executed. And so always I said to my students, now if your synopsis is not properly written, you are confused at the time of writing the synopsis, your research outcome will be usually not appropriate. So planning, execution, and with the execution, documentation, data generation, and then its logical inference, and then conclusion and comparison. This was the method, and we are now still following. Only the terms now we are using it is what? We are using it like literature review, review of the drug, or it is the materials and methods. But this is same what we are doing, and we can continue doing doing this. Not saying that this is what we have taken from the modern advancement. We are continuing with the information which was already there in our textbook. Next slide, please. These are few of the examples I am documenting for you. Observational studies were the part of Ayurveda. These are the examples you can see. When you say at each time of the day, each phase of the night, Vata, Pitta and Kapha, they keep on changing. Was it possible with single human to decide this? It was never possible. Because if you are saying so strongly about it, that in this phase of day, afternoon or night, Vayu is towards the Sanchay, or it is towards the Prakop, or it is back to its normalcy. Whatever Tartam Bhav they are going on, it can never be a one-day outcome. So it might be an outcome of various type of observational study. It may be like a cohort study, or they may have gone for a cross-sectional trials. Similarly, literature review was also there. It was the part of the science. Then there was also some pharmacokinetics and pharmacodynamic studies going on. How they could say Rasaguna Veera Vipak Prabhav of each drug. Without experimentation, it is not possible. When I joined Ayurveda, because this was always very much fascinating for me, that how they could do these things. And in Dravyagun, it was really very difficult to remember all these things, Rasgun, Viryapak, of hundreds or more than hundreds of drugs. And out of curiosity, when I was asking my seniors or teachers, they said that our rishis had the third eye. And through the third eye, they could see everything. But I think so that was not the third eye. This was their experimentations that were going on single herbs. And for that, maybe they had some methods. We are not very sure which were those methods. But based on that only, they could write the Rasguna Viri Vipak and the karma of each medicine, and that it was actually doing its action in the human body also. Not only that, they went for the formulation, and the formulation, it was more than 50 drugs in single formulation. And they knew the effect of that drug, and they even knew which will be the principal drug, which will be the supporting drug, which will be the drugs trying to subside the effect of the potent drugs. So much experimentations were there, and these are all the examples of the clinical trials. Being the students of Ayurveda, do you not always have a question why each drugs have multiple indications? I am always worried about that. If you take Sitopladi, it will be never written that Sitopladi should be given in Rajekshma or it should be given in Kas. It will be like right from Agni Mande, everywhere it is being indicated. What is the answer for that? And why it came? Because they had the knowledge that when you are giving a medication, when the dose is changing, anupan is changing, timing is changing, the disease or disease phase is changing, the effect of the drug will change. And so only they have indicated that if you want single drug, you have multiple indications, but multiple indications are not like randomly. Rajekshma mein, if you are giving Sitopladi, can you give Sitopladi or all cases of Rajekshma? Though we say Sitopladi is one of the medicine for Rajekshma, it is not that all cases of Rajekshma can be treated only with Sitopladi. A typical presentation of Rajekshma is treatable or will respond only to Sitopladi. Somewhere you have to go beyond Sitopladi to other drugs also, because it will depend upon the pathogenesis, it will depend upon the prognosis, it will depend upon the Vat, Pit, Kaph, Avastha. So many things are there. And when they have documented so much, it would not be a one-day effort that they could declare that thousands of formulation with hundreds of ingredients, and with hundred of ingredients, it is multiple indication. So this was their experimentation. These were the outcome of their clinical trials, which maybe have conducted in a way which is not which is being done today, but somewhere evidences are there. Now next slide please. Next slide. So if we are planning research in Ayurveda, we have to see where is our concern and what we want to add for the Ayurveda, and for that what type of research methodology or clinical trials we should adopt. Okay, so the first message from this discussion is that RCTs should be done, but RCTs are not only the solution, they are not only the type of clinical trials which should be adopted for your MD, PG work or PhD work. You should see what you are actually trying to do for the Ayurveda. Ayurveda, if you look, fragmented Ayurveda evidences. There are thousands of works are going on as a PG work, PhD work, but they are never merged together, they are never interlinked, and so there are so many references and so many works. How we do something to it? Then evidence-based Ayurveda practice. We claim many things. मैं कैंसर ठीक कर सकता हूँ, मैं ये ठीक कर सकता हूँ, पर जब तक आपके पास कोई डॉक्यूमेंटेशन नहीं है, कोई आपकी बात मानने वाला नहीं है. So you want to generate a evidence. And what evidence and how evidence you want to generate, that for that, what is the best method you have to check for, and accordingly you should plan your clinical trial. So if you can read, there are various scopes where there is a need of research. You can find out what is your scope, what you research you want, how you want to contribute to your science. Depending upon that, you may go for either it should be a observational study or it may be a clinical trial. Next. So the first thing which is required, understanding the types of research gaps. What is available and what is not, where is the gap and which gap you want to fulfill. And depending upon that gap, you will have your research question. and you will have your hypothesis, and based on that, now you have to decide traditional randomized controlled trials are required or you want a real world data. Because the next topic which is being given to me, it is about the pragmatic trials. How many of you know about the pragmatic trials? Please raise your hands. Pragmatic trials. How many of you know RCTs? Please raise your hands. RCTs. मैं पूछूंगी नहीं, आप सिर्फ हाथ ऊंचा करिए. So very few know about the research that is randomized and pragmatic trial. So RCTs के बारे में तो in the last few slides I have discussed. Now we are slowly moving from the RCTs towards the pragmatic trials. Now RCTs, when we are doing it, is called as the randomized clinical trial. I hope I should not talk on what is randomization. Randomization is where you try to stratify or group, or you make 2 or 3 arms, parallel arms, and in that, based on the method of randomization, your participants of the clinical trials are divided. Okay? None of you are doing RCTs as a PG student now. Second year PG कहाँ है यहाँ पे? Yes. Are you doing some RCTs? So you understand that? But for others, it is just a simple way of understanding something you want to find out, a therapeutic effect of some drug. You want to see it on the patients. So you do what? There should be less of bias. So you try to divide the patients into equally, randomly into 2-3 groups, and in each arm, as per your proposal or as per your treatment groups, you give different treatment to different groups, and then you try to see what is the difference between these 3 groups. Now these RCTs are called as the traditional trials, or sometimes they are called as the explanatory trials. These trials, they are usually done as a part of research in a very strict or a very fixed area, where you are this is the diagnostic criteria, this is the inclusion criteria, this is the exclusion criteria depending upon the disease. I give you a very simple example. I want to work on anemia. Okay, so if you are working on the anemia, you want to see whether Punarnava Mandur is better or Navaya slow is better, Faltrik Quat is better. So these are 3-4 groups. This should not be done, just I am giving you an example. So you maintain the 3 groups. In one of the group you give Punarnava Mandur, in other group you give the other medicine. But for that you have to fix which patients of Pandu or anemia you will take, and which will be included and which will be excluded. So which will be included, only that group of patient is to be taken into the trial, others are to be excluded, and in that fixed number of group you see the effect of drug on a typical investigations, which is called as your primary outcome and the secondary outcome. That you have to decide what you see. You want to see the effect on the hemoglobin, you want to see the effect on the quality of life, if you want to see the effect on the sign and symptom, that you have to decide. But it is very strictly planned, and on the basis of that it is being executed. Okay, but most of the time when these trials are done, it may be not directly applicable in your practice. Am I right or not? If you are in your clinical OPD or IPD, you are giving Punarnava Mandur to your patient. Out of 10 patients, only 3 is responding. Am I right? When you are giving one of the drug, which is a known drug for that particular disease, you add to it, not all the patients will have hemoglobin increase. Few will have, few will not have. This means there is a demand of any other drug which can have the effect of Pandu. So when you all do the RCTs, whatever outcome will be there, it will be applicable to a selected group of patients. It may be not directly applicable in the practice. And so typically in Ayurveda, we need a trial where it can be a real world data analysis. Means what? You have to have a plan where you can select people or the participant on a broader way, and then you give the medication, you try to see the effect, and it is being maintained in a way, it is the requirement of the patient. So you are a little bit relaxed in the pragmatic trials. Are you getting point? RCTs are planned. They have a very selective criteria, and on that particular group only you give the medication, and whatever is outcome is related to that particular group only. And in pragmatic trials, because it is a open trial or open in a way, you can be little bit relaxed on the inclusion criteria, exclusion criteria, and then you are also open to change little bit in the treatment protocol also. I will give you a few examples, so it will be more easier for you. Next. So now we have to do from the research centers to the clinical settings. Daily thousands of patients, all of us we are seeing in the OPD and IPD. And when the patients are coming, even just an example of Pandu I am giving, we never treat all the patients of Pandu with the similar drug. Always there will be a variation, because with the Pandu, patient will have multiple conditions. Even in Ayurveda, Pandu is not Pandu, it is Vataj Pandu, Pitaj Pandu and Kaphaj Pandu, and it is a reclassification, and all the medications which are being mentioned in our textbook, they are as per this pathogenesis, Vataj, Pitaj and Kaphaj. Punarnava Mandur should be given only in Kaphaj, Shodh, Pradhana, Pandu. It is our fixed protocol. But what we are doing, we are giving Punarnava Mandur considering it as a iron deficiency, anemia, and then we are trying a protocol, and sometimes there are positive outcomes and sometimes they are not, because it is not indicated actually there. So in the practice what we do and in the research what you do is a slight difference. And when you actually want the research to be translated means it should be used for the patients, it should be beneficial to all the patients, not a selected group. There the pragmatic trials are more important, they are more preferable, and from my point of view for Ayurveda, pragmatic trials may be a better choice in many conditions. But again I am saying, you have to see what is your question, what is your area of interest. Based on that, but here pragmatic trials, somewhere it can be solution for that. Now there are basket trials, there are umbrella trials, there are adaptive trials. This model has already adopted in the last 2 centuries. But we have kept our eyes closed on it. They also know if it is a case of cancer, single drug may not be a solution for that. And so they have started conducting umbrella trials, or they have started conducting the basket trials, and even they have now adaptive trials. How it is being done, we will see next. So this is the major difference between the RCTs which is being done till now and what are the pragmatic trials. So if you can read, I am not reading to it, right from the purpose till the outcome, you have to see what actually you want and how flexible you want in the inclusion exclusion criteria or in the assessment criteria or the outcome. You have to finalize whether you want to see that the therapy works in a tightly controlled environment or it works in a day-to-day life clinical practices. Okay, and so pragmatic trials, now not only the researcher, even clinicians can do that in their daily OPD setup or IPD setup. Only what is required, you should be, my first slide, properly planned, properly executed, properly documented. Evidence is very important. अगर आप बोलते हैं मैं रोज के 100 कैंसर के पेशेंट देखता हूँ, मेरे सभी कैंसर के पेशेंट ठीक हो जाते हैं, मेरे पास एक जादुई दवा है, nobody is going to believe it. If you have patients of that 100 patients, you have your drug, it is a authentic drug, it is being approved drug, and then you have a document where BT, AT analysis, its documents are there, either they are electronic health proformas or it is a documentation handwritten somewhere, but it is in a appropriate, it is done, then only somebody is going to accept it, adopt it, and then you can be in the competition of proving it as a therapeutic agent. Next. So, because the next part is NCDs and the Panchakarma. So now I will slowly move towards what is this. See, NCDs, everybody of you know that it is some of the non-communicable diseases. And what is a non-communicable diseases? It is the patients who are coming with the lifestyle behavioral changes, and because of that they have started with some Santarpan Utvyadhis, or they have started with some of the conditions which are directly related to the Meda, or they are related to somewhere over-nutrition, or it may be sometime undernourishment, but it has started with a disease phenomenon, right from the metabolic syndrome to it may be type 2 diabetes, hypertension, cancer, or respiratory disorder. So many are there. And when you look at this group of patients, next slide please. In between there is one more information for the interested students. There is one PRECISE 2 wheel diagram. Now PRECISE 2 wheel diagram, it is to show how much is your trial explanatory or practice. This is being developed by some of the scientists to show, or you can prospectively also check where your actually the trial is sitting, because there is a wheel. In the wheel there are 9 spokes, and each there is one parameter, and in each parameter you have to see how much flexibility you have kept, and then you have to score. It is a scoring pattern. 5-point Likert scale is there, and whatever is the score after doing this, your trial is very explanatory, or it is rather or equally or rather pragmatic or very pragmatic also you can do. So if you have already done some trial, you can use this scale and find out whether your trial was actually the mixture of explanatory or pragmatic, or it was a completely pragmatic trial. So this is also freely available. The source is BMJ, and they are there. They have developed this, and they have this. Whenever you are using, you have to cite this. So this can also be taken. So sometimes now it is a mixture of pragmatic explanatory trials. So sometimes it can be together also. So everywhere things are available, only that we are not opening our eyes to the available literature. See, literature review is very important. So modern has already adopted, but we are still running behind it. We have to open your eyes with the information. This is not recent, it is 2009. Updated in 2015, again updated in 2017, now we are in 2026, but we have never followed it. So we have to look for such things which are available and decide where our clinical trials are and which types of clinical trial we are actually targeting for. Next please. So this is what we have talked about, the NCDs, the very common 5 NCDs. Next slide please. Now when you look at the pathophysiology of NCD, even from Ayurvedic point of view or modern point of view, NCDs, they have got multiple factors. They are not a single. See, infection, it is very clear. You have this infection, this is the virus, this is the bacteria, this is the diagnosis, this is the symptoms, this is antibacterial, this is antiviral. Most of the time it works. But when it is a NCD, there will be multiple factors. Aharaj, Viharaj, Kalaj, Manas, so many as from Ayurvedic point of view. And from modern point of view also, look, there are multiple changes at the level of system, and then what we talk about the Agni, arm, everything is getting involved. And then there are multiple organs and tissue damage. And when you are doing a very strong RCT on it, probably it is not possible, because what I have seen in the last few years, if we select one of the drug or formulation for any of the NCD, like just take an example of Pramay or Apathya Nimitaj Pramay, and you are working with one of the medicine, like maybe it is Mamejva Ghanvati or it is any Saptarangyadi. Can you imagine that Saptarangyadivati can manage a case of Madhumeh? It can never, because our principle only says it is being a multifactorial condition. You have to have multifactorial targeted medicine, and there will be so many factors, so only it is called as the whole system. It is a holistic, where you have to talk about Pathya, you have to talk about multiple Deepan, Pachan, so many things, and even the Panchakarma, Shaman, Shodhan, everything gets involved in it. And each patient will have its own requirement. So if you are very strictly doing the inclusion exclusion criteria, you are very strongly saying if it is a Apathya Nimitaj rate, this is the chronicity, this is the blood sugar levels, and so many things are there, you are very strictly bound, and then we say in this particular group of patients of Apathya Nimitaj Rame, Mamejva is effective. Then we can do that. Otherwise, we have to be open, because we have to target so many things. And the adaptive trials or pragmatic trials will be a better option for it. Next. Similarly, when we are talking about the Panchakarma procedures, when we are giving it as a part of the NCDs treatment, it has to be also, we usually do what? I will take a study where I will perform a virechan in a cases of tamak shwas, and then I will try to compare with those group with the patients who are taking the shaman treatment. Is it possible in Ayurveda? It is never possible, because shaman का indicator कोई और है और शोधन का indicator कोई और है. दोनों ग्रुप के पेशेंट का ग्रुप ही अलग होना चाहिए, because indication of virechan is also very typical. All cases of tamak shwas cannot go for virechan. All cases of madhumeh cannot go for virechan, because in a typical phase of a typical disease only, shodhan is applicable. Rogi ka bal, kal, those so many factors are there. And how you can randomly say that virechan is the best treatment for psoriasis, or it is best treatment for the ekakoshta, or it is best treatment for hypothyroidism. So when it is a multiple factor and you are targeting a multiple effect, you have to see where you want to have this effect, and for that what can be the best way of underscoring the inclusion exclusion criteria and the assessment criteria, and based on that you can plan it. So in Panchakarma procedure also we have to think for that. Next. See, these are some of the documentations from the previous study where we are saying, but very broadly saying, virechan is having some effect in the metabolic syndrome or in the cases of psoriasis, and then as per the outcome of the study, somewhere we are able to see that virechan is reducing the disease severity, it is increasing the quality of life, but still it will be 2-3 such protocols, and on the basis of this we cannot have a concluding remark that for any cases of metabolic syndrome virechan can be given. In metabolic syndrome also there are different way of diagnosis, and there are different components which are involved in the metabolic syndrome. In which component, in which phase virechan is applicable, that is actually our target area. So if we are planning like this, somewhere we have a broader outcomes, but this outcomes has to be finalized, and for that maybe we have to go for any other trials other than the RCTs. Next. Similarly, there are some clinical evidences that osteoarthritis and some of the drug, they have some of the positive effect. But these are the outcomes from few studies, not from multiple studies. But these are the leads. See, whatever we are doing now, they are giving us some leads. And on the basis of these leads, we have to plan an appropriate large sample clinical trial to generate evidence for that treatment protocol that we can now call as the standard treatment protocol or guideline for that particular disease in a difficult presentation. Next. Next please. So now if you are planning a pragmatic trial, multiple component, so you have to see different things out of it. What is your question? What is your selection criteria? What will be your drug? Whether it will be add-on? What will be your outcomes? These all factors, they are there, and whether you want a real-world data with a minimal burden, and whether you want to see the efficacy or effectiveness. There is a difference between these two terms. So if you are targeting for the effectiveness, you have to go for the pragmatic trials for non-communicable disease. Due to the shortage of time, I am not going into very details. I am just trying to give you a hint how we can proceed in the future. Next. This is one of the examples, because sometimes always saying something without proof, it is like bhashan bari. So because I was too much disturbed in the few years what the research protocols we were preparing, we just went 3 years back with a research protocol. This is not the first one already being done, but it is how it is being documented as a part of PhD work. It is COPD, one of the common non-communicable disease. It is a advanced stages of the bronchial asthma where the patient has breathlessness, and their COPD, when I was going through it from the modern point of view, I could trace, this is how it is called as the literature review. The modern medicine already have phenotypes of COPD. Previously they were saying that the blue buffers and the pink buffers, now they have put it as the it is dominant, or bronchial chronic bronchitis predominant, and even there is a overlapping with the bronchial asthma. Now they have so much category of COPD. And we from Ayurveda point, already we had everything documented, but हम क्या करते हैं? COPD case, this is modern medication, this is Ayurveda medication, COPD में Ayurveda काम करता है नहीं करता है, पर वो कैसे काम करेगा अगर आपने उसको उस वे में प्लान ही नहीं किया. So we just thought, why not divide our group in a case? It was again a type of RCT only, but it was RCT based on the subgroup analysis. So one group we did only control group, we did nothing, but in the control group also we categorized that whole control group into Vata Pradhan and Kapha Pradhan. And again Vata Pradhan into Vata Balwan and Vata Durbal, Kapha Balwan and Kapha Durbal. It is nothing from my side, it is being mentioned in the Charutar. So we redivided the whole 50 patients into that subgroup, and in the treated group also we again redivided all our patients in this. It was a little bit difficult trial because it was not an easy process which are usually doing. It was something different, but we tried to it. And again, we in the treatment group also we stratified the patients into 4 groups. Again, Vataj Kaphas and Vataj Kaphas again 2. Each had its own treatment protocol, and each treatment protocol was as per the principles of Ayurveda, what is being mentioned. We went through various classics, found out what could be the best medicine for Vata Balwan, Vata Durbal, what can be, and based on that we selected the procedures and the medications, and in that setting only, in the same way, in a control with the placebo and in a standard with the treatment, we followed all this group. Nearly a patient of 90 or that we could able to do it, along with the diet and lifestyle and breathing exercise, because it is a protocol always in Ayurveda. It can never be a single drug therapy. Next. And then after doing that, in the parameters which are very much important for the COPD prognosis and quality of life health assessment, that is PFR, FEV1 and CAT score. Based on that, I'm finishing. Yes. So based on that, again we could see that each group performed in a different way. Though the treatment was very similar, which was being mentioned in the textbook. So from this leads we could get that our protocol or Ayurveda protocol as a add-on, again I am repeating, this is a add-on protocol of the interventional group also. We cannot withdraw the patient's medication of COPD because it is a progressive conditions. They are dependent on modern medication for very long, but still as an add-on we could find something out of it. And then this is again the first trial, so we have got the lead. It is not a conclusion on it because it is a limited patient data, but something different is being done. Next slide. And somewhere the outcome we could say Vataj phenotypes attain most improvement in PFR percentage, while Vataj Durbal could have a better in the CATs. Now how it happened, why it happened, we are trying to analyze, and we are putting it as an outcome of our thesis, which is being nearly completed now. But still it is a beginning which is little bit different. This is, I know it is not the first type of his work, but this is the way we can change from the RCT. And these are going to give the solution what actually we are looking for. Next. Next slide please. Similarly, when we are trying to do the Panchakarma procedures, Panchakarma also has its own indication, contraindication, and it cannot be randomly given to any patient. सबसे पहले तो शोधन योग्य होना चाहिए. शोधन योग्य होने के बाद भी वमन योग, विरेचन योग, बस्ती योग, नस्य योग, कितना कुछ है उसमें, और उसके भी 10 पैरामीटर्स हैं. उस 10 पैरामीटर्स में जब वो क्वालिफाई होता है तब उसको मृदु, मध्यम, तीक्ष्ण, कैसा विरेचन, वमन, शोधन करना है. It is a very vast science, and in that also we need something different from the RCTs into this form. So again we have to rethink what procedure we are planning, which conditions we are planning, what will be our inclusion criteria, what will be our exclusion criteria, and how we will add and minus next. And so, and even for the complication also, we can plan something like that, where we are trying to document everything, and as per the documentation, we are trying to prepare some of the SOPs or guidelines where the variation can be the best, or which procedure of Panchakarma can be best indicated in which of the disease stage. I will not say disease, the phase of the disease. Next. So if we want to prepare some safety protocols, we have to think of already which is being mentioned in our text, nothing new. Ati yoga, ayoga, heen yoga, and probably whatever are the upadravas which are being mentioned, the most common upadrav which we see usually in the patients of Vaman Vyapat or Virechan Vyapat in our clinical setup, that we have to start documenting probable cause and what is this, and based on that we may generate some evidences, and then we can say, in the books already it is being mentioned, it is nothing new, but now it is the way we can put it in a text document saying that if this is the complication, probable you find the causes, and if it is this, probably this is the best line of treatment and that is the best management for that Vyapat we can do. So this is why safety protocols also can be developed, and it is already in the process, but still not completed at many of the institutes. Next. Similarly, when we want some individualized protocols and standardization in Panchakarma, we have to go for various components which I am discussing. There are so many things, so considering all these things, fixed protocols are to be prepared, and accordingly if we start documenting, then we will be able to generate a data saying that which Panchakarma procedures are effective and probably by which mode of action it is giving this action. Next. Similarly, properly when we are talking about the IEC ethics approval, we also have some groups which are called as the vulnerable groups. So in that groups also, what we have to think, what are to be considered, like this is the group of the patient, what are the risks, how we are doing the risk assessment, as per that, how we are modifying the Panchakarma procedures. Actually already it is being there in our textbook, so from that we can take a lead, and then safety outcomes, probably on what basis we can prepare. There can be some leads for that, and as per that there can be some data generation. Next. This is also one of the very important thing. Rasayan, a unique concept. And when we are giving Rasayan as a part of our treatment protocols, we take it for 3 weeks, 10 weeks, 12 weeks, 3 months. But it is like a long-term effect is there. And to see the sustain, we have to plan some sustain effect models. It may be already available, we can select, or we can plan something different from that, that right from the Panchakarma procedures till the effect of the Rasayan as a post Panchakarma procedure, how we maintain the whole data, and then we can generate and say that probably when you give a particular Rasayan as per the nemetic Rasayan in a particular disease, for how much duration it is being there, then we get the least effect and how long it can be continued. One of the project it is being going on, there it is a pharmacokinetic study of the Rasayan drugs. So how these drugs are doing the action, we are trying to find out the solution, but at least from the clinical data, we can have some evidences for that. Next. But sometimes, whenever I am saying, I am very confidently saying that pragmatic trials are the need, but it is like, again we have to think. If we are adopting the pragmatic trials, there may be some good part or there may be some negative parts. So every things will have a better part or the other part. You have to decide that if you are considering a pragmatic trials, probable complications or probable data may be affected somewhere. What can be a solution? See, in RCTs also we say that it is free from bias, but somewhere there is. So we have to declare our limitation at the end of that trials also. Similarly, if we are doing pragmatic trials in a specific conditions of Ayurveda, you have to say this may be the probable outcomes which will be benefited, and this may be the limitations of the trial. Next. Next slide, please. So, this is the take-home message for us. We have to adopt. Adopt means we have to adopt whatever is going on, not in the way what modern medical science is doing. We have to adopt something for ourselves. It will be self-generated also. Never we should be dependent on somebody. So what we can do and adopt, how we can standardize it, how we can harmonize, strengthen, improve, leverage and build. And if we are able to do, I think this is the best way we can afford, or we can do some contribution to the advancement of Ayurveda. Thank you so much.
For your insightful lecture on pragmatic preclinical and clinical research in non-communicable disease, with special emphasis on the Panchakarma efficacy and safety. Your scientific approach and clarity have added great value to this session. Thank you for sharing your experience with us.